per month. So around the January, February time. I encourage you to reach out to us by email if you have suggestions or thoughts on future topics that might be helpful to you in your practice, so we can consider those for the next round of echoes. And we can be sure, if you have speakers in mind, you can also provide contacts for those as well. That would certainly be helpful and much appreciated. For those that do not know me, I'm Catherine Freeland. I'm the Associate Director of Public Health Research at the Hepatitis B Foundation. And I apologize, I hope my signal will be okay. I'm joining from the Conference on Liver Disease in Africa in Cairo, Egypt right now. So my service may be a little spotty, but I have my colleague Fiona on the line. I'm gonna let her introduce herself, and she'll be able to support with backup technical assistance if needed. So Fiona.
Hi, everybody. Thanks, Catherine. My name is Fiona, and I work at the Hepatitis B Foundation in Doylestown. I'm really looking forward to joining this Echoes. It's my first one, so I'm excited to see the topics and the discussion that happens today. Thanks.
Thanks so much, Fiona. And we have a couple of our ECHO advisors on the line. So Dr. Torgerson, if you wanted to introduce yourself.
Hello, everyone. I'm Jessie Torgerson. I'm an infectious disease physician at the University of Pennsylvania, and I run our Center for Viral Hepatitis at Penn Presbyterian Medical Center.
Thanks, Dr. Torgerson. Haley Michael, I see you're on the line as well, and you also helped us really start the ECHO. I wonder if you want to introduce yourself if you're able.
Hello, I'm always happy to be here. I'm Halim Saling from Ethiopia. Thank you.
Thank you. Perfect. So I think I see more people joining. So just again, if you're just joining the meeting now, please feel free to introduce yourself in the chat. So today we have a really great session. Dr. Cami Graham, we're really happy to have her with us today to be presenting on hepatitis B and co-infection. She's certainly an expert in this topic, and I think we'll be able to really shed some light on this important topic, and also thinking about how we can continue to think about integration and co-infection in the same space. So I'll hand it over to Dr. Graham, who will be doing our case or our didactic for today. So welcome.
Hi, I'm super excited to be here. And I'm going to try to keep things very practical. Let me share my screen and get this on slide view. Is that happening?
Yep, it looks good. And now it's in presentation mode, so you're all set.
Okay, fantastic. All right, so you all are focusing on hepatitis B. I'm going to make some assumptions about things that you're normally doing, but now we're going to imagine someone living with HIV or someone in a program where you're trying to prevent HIV, and how does their hepatitis B status affect their care? Oh, and by the way, I'm at Beth Israel Deaconess Medical Center. I've been there for 25 years, but I'm also medical director at a program called Program RISE. It is a community organization. It's not a clinic. It does harm reduction services, syringe access, STI screening and treatment. But we realized that people weren't going to traditional medical centers. They didn't feel safe or comfortable there. And that we needed to bring care to the people. So we've integrated a lot of medical care, including PrEP and Hep C treatment and hepatitis B screening and vaccination into this. And so some of what I talk about will be coming from working within this, this sort of non-academic setting. Okay, I have no disclosures for hepatitis B. For hepatitis C, I write the treatment sections for up to date of hepatitis C. Okay, so we're going to start by reviewing screening for hepatitis B in people living with HIV. Describe the serological patterns that are commonly found for hepatitis B in people who also have HIV, and how that's going to impact your co-management of both of these viruses. Review recent data on hepatitis B vaccination in people living with HIV, understanding that not everybody has access to all of the different vaccines. Management of active hepatitis B, and then how hepatitis B status affects HIV prevention efforts. So a lot, I'm just going to try to move pretty quickly here. All right, so I've got a little bit of a US bias. I do apologize for that for the international folks, but I think a lot of what we do really is practical across across other settings. And so because hepatitis B status really impacts a lot of decisions you're making around HIV care, whether it's active care or prevention, everybody needs to have their hepatitis B status characterized. You're finding those individuals who have chronic active infection that are going to need further management, unexposed people who need to be vaccinated, and people who've been exposed, currently immune controlled, and could be at risk for reactivation. And so we really recommend all three serologies: surface antibody, surface antigen, and core antibody. And I'm going to talk about some of the implications of these different serological results. And so often what you'll look back at your chart and you'll see, oh, this person only had a surface antigen, or this person only had a surface antibody. If that's the case, go ahead and get all three serologies if you're able to simultaneously, because otherwise, because the status can change, you end up second guessing yourself. At Beth Israel Deaconess, we found that we were having a lot of ordering errors. People were ordering all sorts of combinations of hepatitis B serologies that weren't particularly helpful. So we put them under an umbrella called the hepatitis B screening panel, where you get the three you're supposed to get and not anything extra. And if you've got that ability, I recommend doing that for people. It just makes things a lot easier. And so here is a chart of what you're going to see if you do the screening program. And we're going to spend some time talking about that person who's surface antigen positive, who has active infection in the setting of HIV care. But I'm also going to describe the person who has what we call isolated core antibody, because it's relatively common in people with HIV. And the number one question I get is, do we need to vaccinate these individuals? And I've put in this chart, this is row 4. No, you do not need to vaccinate them. I think there's actually good data that that vaccination in individuals with HIV does protect them from chronic hepatitis B infection for life, which is encouraging. I'm only going to mention this here. You will occasionally see somebody who is isolated surface antigen positive. It is almost always either that they had carryover from a test that was done before that test, because these tests are exquisitely sensitive, in which case don't repeat the surface antigen on that same tube. You'll have to redraw the tube. But more commonly, that person received a hepatitis B vaccine, which has the surface antigen that can be detected by these tests within 2 to 4 weeks, and you're actually picking up the vaccine. And in that case, either one of them, you're repeating that test in 30 days. Okay, so probably one of the most common questions I get about hepatitis B in people living with HIV is, what do you do with the person who's isolated core antibody positive? And the first possibility is that this is a false positive. But when you actually look at people living with HIV, this is almost never the right answer. I want you to never assume that this is a false positive, because it can lead to some dangerous assumptions for patients. And so that's in red, because that's almost never the answer for this population. Probably the most common thing that happens is people gradually lose their surface antibody. So they had prior infection, they had surface antibody and core antibody, they lost their surface antibody, but they still have good immune control. And that's in distinction to the person who has lost immune control. And this is the person who has occult hepatitis B infection. That's defined as someone who has detectable HBV DNA. And the challenge is, this is a not completely uncommon scenario in people living with HIV. It's a little bit hard, somewhere in the 2 to 10%, depending on the study, depending on the population. But this is something that can happen. And these individuals are at risk for loss of control and flare of their liver enzymes if you don't recognize that they have a occult infection. And then the last one is this could be someone who's actually acutely infected with hepatitis B. Most of these core antibody tests are actually detecting a total core antibody, and it's a combination of IgM and IgG. And what you might actually be picking up is the IgM, that early antibody that develops after acute infection. And this is the one time that if you can, you're going to be checking that IgM anti-core antibody. But usually you're thinking about this because this person also has higher liver enzymes than you would have expected. They're going to be often in the hundreds, sometimes they can be in the thousands, and that's what's going to cue you in that this can be acute infection. Okay, so this is just to remind you of the life cycle of hepatitis B and why I'm saying if you're core antibody positive, you need to assume that that person has hepatitis B DNA in their liver cells, in their hepatocytes. And that's the far left corner. You see that circle, that red circle around the cccDNA. This is closed circular covalent DNA. And when someone has been exposed to hepatitis B, the hepatitis B creates this kind of mini chromosome called cccDNA that's in the nucleus of the liver. And as long as the person has good immune control, this cccDNA does not cause trouble. They don't have any increased risk of liver cancer or liver fibrosis or anything. But if you lose immune control, this can reactivate and start replicating, and then people can have flares of liver enzymes or all the other complications that we know in active hepatitis B infection. Okay, so so risk of occult hepatitis B. This is the reason that this ends up being particularly important is we now have some regimens we're using that are non-tenofovir based regimens. And I say that because tenofovir tends to be the backbone in most of the world. It's a fantastic hepatitis B drug as well as HIV drug, but we've got non-tenofovir containing regimens. They might contain lamivudine. That does not have a good barrier to resistance for hepatitis B. They might not contain any nucleotide analogs. In these individuals, you now are choosing a regimen that does not cover hepatitis B. And if you miss the fact that they have occult infection, they can get into trouble. I've got here 7 to 19 people with HIV. And that really depends on the population. If you've got individuals who are also hepatitis C co-infected, this rate is going to be higher. If you have, from a U.S. perspective, we have a large international population. If individuals are immigrating from hepatitis B endemic countries, this is going to be higher. For those of you that are coming from countries that have a relatively high endemicity of hepatitis B, you're going to see this more often as well. And so if you can, you're going to check a hepatitis B DNA level, a viral load, in people who have CD4 counts less than 200, people who have elevated ALTs, even if you think you know why their liver enzymes are elevated, or if they are about to start hepatitis C treatment. Go ahead and note, if you see that DNA, occult hepatitis B infection in the problem list, so other people don't miss it if they're, doing things that this status might be relevant. And you're going to treat these individuals the same as people who are surface antigen positive. That's the easiest way to think about this group. Think of them like people who are surface antigen positive. Okay, now let's go back. You've got people now who have all negative serologies, and you need to vaccinate them. So hopefully you have a hepatitis B vaccination program within your overall clinical program. People who also have HIV are more likely to progress to chronic infection if they're exposed than people who don't have HIV. they are less likely to respond to the older hepatitis B vaccines like Engerix-B or Combavax-B, somewhere in the 40 to 70% range. Effective vaccination with good seroprotection, elevated hepatitis B surface antibody after you vaccinate will protect against chronic infection. You can actually have people actually get exposure and become core antibody positive. And I think that's only going to be relevant in the reactivation standpoint. But the number one thing is you really try to vaccinate them. And this is a group of people that you're probably going to check a surface antibody a few months after the vaccine just to make sure that they responded. There's no need to vaccinate isolated core antibody people. Just keep in mind that they're the ones that are potentially at risk for occult hepatitis B. Okay, so I don't know how broadly this particular vaccine is available, but it's one called Heplicate-B. It was approved maybe like 5 or 6 years ago in the United States. And this was a great study done by the ACTG, Kristen Marks, that looked at 75 people who had HIV, good CD4 counts, almost all of them were suppressed, and they vaccinated them at baseline and then again at 1 month. And then they gave an extra vaccine at 6 months. It's a little bit unclear to me why they did that. And we actually haven't seen the results of what happened long-term with that group and whether it really makes that much of a difference. But what you can see is with the 2 standard doses, 98.5% of people had responded with good levels of surface antibody. This is the highest rate of response we've ever seen in individuals who are also living with HIV. Okay, so the baseline labs that you need to get in individuals who you find are surface antigen positive and have HIV are going to be very similar to the ones you get in people who don't have HIV. And so this shouldn't be any surprise. But now you're just, instead of putting your HIV hat on, you're putting your Hep B care hat on, and you're reminding yourself that this is somebody who needs an assessment for risk factors for liver disease like alcohol and metabolic risk factors, evaluation for advanced fibrosis and cirrhosis, look for that history of family history of hepatocellular carcinoma, labs. Everybody needs a Delta hepatitis D antibody who is surface antigen positive, whether or not they have HIV. So I think all this should be standard for you. So what are, when you're treating somebody who has HIV for their hepatitis B, what are some things to keep in mind? I already said everybody needs to be tested. If you look back and you see in their testing that they didn't get all 3, go ahead and repeat the full panel. If you do find that isolated core antibody, it's actually not recommended to check HBV DNA in all patients. You're looking for those that are at increased risk for occult infection, and so that's going to be people with low CD4 counts, elevated liver enzymes, about to start a non-tenofovir containing regimen. You're thinking about starting cabotegravir, rilpivirine, or dolutegravir, lamivudine. Then that individual, you need to check a DNA. You're about to also start Hep C treatment. You want to know if they actually have detectable DNA, HBV DNA, and then again, country of origin with a high prevalence of hepatitis B. And we will more frequently see occult hepatitis B infection in individuals from sub-Saharan Africa. Okay, you're going to start everybody, if you can, who has surface antigen positive. Really, everybody who's surface antigen positive, you need to be trying to figure out how to start them on a tenofovir-based regimen. Tenofovir can be taken with or without food for HIV, whether you're doing TDF or TAF. But if you are also treating the hepatitis B and you choose a TAF-containing regimen like Biktarvy, you have to tell people to take that regimen with food for the hepatitis B activity. It's one of the most common misses I see in clinical care of people who are co-infected is that they don't tell that person on Biktarvy that they need to take it with food, and then the hepatitis B viral load is elevated and they don't know why. And if they consistently have the person take it with food, it goes back down to undetectable. The other thing that we've seen in research is that people taking care of folks living with HIV who also have chronic hepatitis B infection, they're not doing a good job monitoring the hepatitis B. And I think one mistake people make is thinking that because the HIV viral load is suppressed, that they must be good enough from the hepatitis B standpoint as well. Keep in mind, usually we're using multiple drugs for HIV suppression, and often you really have one good drug, the tenofovir, for hepatitis B suppression, and you probably need higher levels of adherence for hepatitis B suppression than you do HIV suppression. And so every time you check an HIV viral load, check a hepatitis B viral load if you have that ability. If it's difficult to access hepatitis B viral loads, then check an ALT. And if that ALT goes up, then try to figure out how to get a DNA level, or assume that that could mean that person actually has elevated hepatitis B DNA levels, and what you're going to be doing is reinforcing adherence. Okay, if you're checking serial viral loads, each level should be lower than the previous level. It can take 2 to 3 years for people living with HIV to become undetectable in terms of their hepatitis B viral load. So this is another common question I'll get is, oh my gosh, I'm used to the viral load with HIV being suppressed in 2 months, 4 months. It's been 2 years and they're lower, but they're not undetectable. Do not despair. But if the DNA rises, the number one thing you're going to do is reinforce adherence. It's almost always an adherence problem. And then if they're on a TAF-containing regimen, taking it with food. Don't forget to screen for hepatocellular carcinoma, same as people who don't have HIV, every ultrasound every 6 months, plus or minus alpha-fetoprotein. And that's for everyone who's surface antigen positive and age greater than 40. Sub-Saharan Africa, I think you all are standardly starting people at age 20. That's in our guidelines in the United States for people immigrating from that region. All right, if you switch anyone who has HIV to a non-tenofovir containing regimen, I've given a couple of examples that are commonly used. First, either check or recheck that surface antigen to make sure you're not accidentally taking them off needed hepatitis B treatment. So even if you got a surface antigen 3-5 years ago and it was negative, go ahead and recheck it just to make absolutely sure that they didn't get exposed to hepatitis B. Unlikely, because actually that HIV regimen is actually, it's like pre-exposure prophylaxis for hepatitis B, but maybe they have a lapse in their adherence. You don't know. Just make sure you're not accidentally taking them off hepatitis B treatment. Every time I go to a liver meeting, multiple hepatologists have to tell me about the patient that did not have their hepatitis B recognized, got switched to Cabenuva, developed severe liver failure, maybe even died of their liver failure because of unrecognized hepatitis B. So don't do that. If they're isolated core antibody, those people have very low viral loads. If you do detect virus, you're not going to detect it on a tenofovir containing regimen. The key is you're monitoring that ALT when you switch them to a non-tenofovir containing regimen. And if that liver enzyme starts going up, you need to check that HBV DNA for reactivation before they run into trouble. Okay, so I've sort of reinforced this, but just a couple of key differences about TDF versus TAF. Is TDF can be taken without regard for food. It can be given to people with decompensated cirrhosis. You're obviously carefully monitoring their renal function. And there's a risk of severe acute exacerbations of hepatitis with discontinuation. With TAF, has to be taken with food for the hepatitis B treatment. It can be given to people with compensated cirrhosis, Charles A, but not decompensated. If they're decompensated, you want to use TDF. Okay, last couple of minutes, just talk a little bit about PrEP. So everyone being considered for PrEP needs to be tested for hepatitis B infection. I'm assuming this is assuming that you're anybody. So even if you're thinking about Cabenuva, cabotegravir, for PrEP, you need to test for hepatitis B because you don't want to be accidentally not recognizing that this is somebody who has chronic infection. Vaccinate everybody with negative serologies. If you've got a PrEP program, really try to integrate vaccinations into that program. You're keeping in mind that a tenofovir-based PrEP regimen is also going to treat that person's hepatitis B. And we're really thinking about those folks that you find that are also surface antigen positive. And so they need to understand this, that they actually are also being treated for hepatitis B. You need to do a full evaluation for their hepatitis B, labs, ultrasound, everything else that you would normally do for anybody else living with hepatitis B. And you need to monitor them, ALT, viral load declines, like anybody else on hepatitis B treatment. So you have to kind of think about the PrEP hat. Now I'm using this to treat the hat. And then you've got to go over and put your Hep B treatment hat on. I'm treating them for hepatitis B because those aren't the same. It's not the same care pathway. You'll see in all sorts of guidelines that abrupt discontinuation of PrEP may increase the risk of liver flares due to hepatitis B reactivation. This risk is actually highest in those who have more advanced liver disease. So if you have somebody, who, whether you're using FIB4 or transient elastography or something to determine their probable degree of scarring, fibrosis, it's those that have more advanced fibrosis that are going to be most at risk for these severe liver flares. And then this is just a reminder, these individuals really do need more extensive counseling. Block out the time to really make sure that they understand what it is they're doing, and that they can't just decide they're going to stop treatment without checking in with you. I think there's a really interesting aspect of putting people who have chronic hepatitis B infection on PrEP for their HIV prevention, because that let's say it's tenofovir FTC, it's preventing them from acquiring HIV, but it's probably also decreasing the risk that they would transmit hepatitis B to others. This is a U equals U idea for hepatitis B. Now, we don't have the data to support this like we do with HIV, but what I say to people is we've got experiences with tenofovir for reduction of transmission in mother to child. We've got occupational health approaches, and that, keeping in mind that this may be an added benefit of this treatment. So what they also need to understand is they cannot use event-driven or 2-1-1 PrEP. They need to really be careful with adherence. They may read, if you take PrEP like 4 times a week, you're okay. Not if you're also treating their hepatitis B. And if somebody's like, this is just too much for me, I'm not ready to do this. I'm 22 years old. I don't actually meet criteria for hepatitis B treatment independently. This is somebody that you're going to consider something like cabotegravir. Now, whenever I talk to people about PrEP, I talk about the entire continuum from PrEP to PEP. And if somebody decides they're not ready for PrEP and of any form, then always remind them that they can always come in for PEP, post-exposure prophylaxis. And there, I usually consider a non-tenofovir containing regimen. I've used AZT plus boosted darunavir plus dolutegravir. And keep in mind, if somebody, may be in a situation where they don't have access to a place of care that could give a novel PEP regimen, that you might want to actually give them PEP in pocket. And I think that's actually it. I'm going to stop sharing, but if you want me to go back to anything, I guess I could.
Thank you. That's super helpful. I encourage any of the participants on the line to raise your hand if you have any questions or comments. for Dr. Graham. I did have a few questions because I think you did a great job at really giving a high level overview, and we did have some positive feedback already in the chat, so be sure to check that out if you haven't. But one thing that I always see a lot, and we've done some work screening in the harm reduction community, particularly in Philadelphia, and I think really universally we have a really big challenge with addressing both HIV and hepatitis of all types in the harm reduction space. And I think this is often overlooked, particularly in our developing parts of the world as well. But needless to say, I wonder if you could maybe shed some pearls of wisdom on how you've really thought about addressing loss to follow-up in these communities and how we might be able to do a better job at making sure they're coming back, because it's oftentimes this is a transient population.
Yeah. So, I mean, I think there's some fantastic models, and I think Philadelphia has some great examples of ways of keeping vulnerable populations in care, who have a lot of competing psychosocial issues, and sometimes their healthcare can't be number one. They're trying to survive. And so, I think, when I first started working at Program Rise, I had this whole, like, I don't know, scheme that we were going to have a van that was going to take people who really wanted, the specialty care that I provided at Bethersville Deaconess, into Boston. And, because I've got, nurses and PharmD and labs and, all of that in there. Zero people came. Nobody came. We did peer counselors, like all sorts of stuff. And then finally I'm like, oh my gosh, I've got a lot of folks living, especially with hepatitis C. And I guess we need to bring care to them. And so it's the idea of bring care to the people where they feel most comfortable. And I think it's something that some areas, some countries do really, really well. And I think the bias in the United States is you will come to me, you will come to my clinic. And so I think this is one where we can really learn from each other, but figuring out where people come for whatever it is. So at Program Rise, they're coming in regularly for housing assistance and food security and Narcan and clean needles and everything else, STI testing. And so we made sure that the entire team, whether they were behavioral health or whatever their role was, understood the goals of our programs. We have over 100 people on prep, 150 people on prep. Everybody's part of that care team. And so, everybody can say, hey, by the way, how are you doing with this? Oh, you've got a little nausea. Did you talk to the nurse practitioner about this? Because there's things that they can do. It's everybody, and especially with the hepatitis C, as people started seeing, folks that nobody was giving them credit to be a treatment candidate, you're not going to get treated, seeing them go through treatment, seeing them succeed, seeing them be cured, seeing how happy they were, it's really gratifying to everybody. So, I think the first thing is, are you spending a lot of time trying to figure out how to get people to you and how to keep them in care with you, or are you thinking about how to bring care to them?
Thank you. I think that's a really great response and very comprehensive. Dr. Torgerson, I see you have your hand raised. Feel free.
Thank you. And Dr. Graham, thank you so much. That was really a wonderful talk and comprehensive. I particularly liked the recommendations for Hep B reactivation screening and those being switched to our long-acting injectables. I had one question, and you had mentioned for people with HIV with isolated core antibody to hepatitis B, you do not recommend vaccination, but we see that with Department of Health and Human Service guidelines suggest that isolated core patients should be vaccinated if they're living with HIV. And so I'm wondering, that's I think a B2 recommendation, so not tremendous amount of data. Wondering if you could sort of compare and contrast your recommendations and sort of what, if any, data you think are needed in that space to help our clinicians.
Yeah. So this is a fight that I've had with Raj Gandhi for over 20 years. And here's the thing. They have hepatitis B inside of them. They already have hepatitis B. Now, there was a really interesting study that came out a few months ago, not with HIV, but with cancer chemotherapy. I think these people were undergoing CHOP or something. And they had people who naturally had hepatitis B antibody because they had prior infection. And they were going to now have their, immune system wiped out with chemo. And then you had people who No, actually, they had gone through chemo and now it was post chemo and they were trying to decrease the risk of reactivation. I'm sorry, that was it. And then you had people that got vaccinated. And the people that got vaccinated had elevated antibodies, but it didn't end up actually protecting them like the core, like the natural antibody did. And what it took from me was you can vaccinate these people and you can get elevated titers, but when push comes to shove, if they become immunocompromised and are at risk for reactivation, it doesn't actually protect them. And otherwise, if they're not at risk for reactivation, nothing happens to these people. They don't have an increased risk of cancer or anything. So my question is, what are you doing? What are you doing? What are you trying to achieve with that? Yeah. So that's the answer.
Thank you. Another question, I really appreciated you bringing up Delta as well. I wonder if there are any implications for HIV specifically with Hep B, Hep Delta co-infections.
Yeah, the cohort studies suggest that people may be at increased risk, for Delta co-infection. But I think what we've learned over the years is we are terrible at trying to identify who's at risk. We're missing at least 50% of people who don't have what we think of as traditional risk factors. And so, this is just one of many groups where you really have to just universal Delta testing for everybody who surface, antigen positive.
Thank you. A question came through the chat. We've got a couple of them actually. Thank you for the presentation. In the context of HIV hepatitis B co-infection, what influence do levels of integration of the Hep B genome into the host DNA have on the pathogenesis of occult hepatitis B?
Yeah, that's a great question. So this integrated hepatitis B, it's not the same integration with HIV. So HIV integration is an absolute critical part of the life cycle. If you block integration with an integrase inhibitor, you block replication. With hepatitis B, it's not necessary for its life cycle, but it's a transcriptable, if that's a word, genetic material. And so some of the proteins that you see, like surface antigen, E antigen, are actually coming from that integrated genetic material and not the cccDNA. But the cccDNA, that free like mini chromosome in the nucleus, that's the site of transcription and then translation into infectious viral particles. I think the most important thing I keep in mind in terms of the phenomenon of integration is it starts immediately with infection. Children that had perinatal transmission have had countless episodes of this genetic integration into their chromosome by the time they become adults. This genetic material integrates into every single chromosome, including X and Y. And it's probably one of the reasons why people are at increased risk for liver cancer, because it's disrupting suppressors and promoters and, and all sorts of other ways that you get regulation of cellular function, that if you don't have that, you get cancer. And so I think the thing that I think is the most interesting is, as we get smarter about this, are we going to really think of hepatitis B suppression much earlier in the disease course to reduce the risk of these integrations and eventually decrease the risk of liver cancer? I don't think we're there yet, but I tend to be sort of more favorable towards antivirals and people that are open to it, that are on the younger side. I'm an adult doctor, so I'm not seeing anyone under 18, but those early 20s people, they're still kind of immune tolerant phase, but but is there harm of this integration? I think we've got evidence that that's probably going on.
Yeah, definitely. Thank you. You mentioned for co-infected HIV hepatitis B, it takes about 2 to 3 years after treatment initiation to see undetectable DNA. Do you know about monoinfection and what that timeline is, generally speaking, for undetectable DNA levels?
Yeah, in monoinfection, people are going to lots of people are going to be undetectable by a year, but you can still see some people, taking 2 years or more. Now, if you're treating somebody who's got a viral load of 1 billion, and that happens, it can take quite a while for it to decline. Now, for those of us that came from an HIV care background, we get really anxious if that HIV viral load wasn't coming down pretty quickly because we worried about the development of resistance. With hepatitis B, that doesn't seem to happen, especially with tenofovir-containing regimens. And I've spent 20 years, puzzling over why. I'm not a hepatitis B virologist. I don't really understand, but it doesn't happen. And I think that's the thing, to keep in mind is it happens faster in people who are mono-infected, but it also depends on the where you're starting, from in terms of the viral load. And in 60% of people with HIV are going to be undetectable by year 1, 80% by year 2, and kind of the rest of them hopefully by year 3. The main point I was just saying is don't flip out about it. I always reinforce adherence. And that's just, and I think, we've gotten maybe those of us that have spent a lot of time in HIV because, we used to in the 90s spend a lot of time talking about adherence because you had to have basically perfect adherence with these not very good regimens. Now it's like, you can probably get away with not being quite so careful. With hepatitis B, you probably need more adherence. And so, that's just your reminder, always reinforce that.
Yeah, thank you. Really appreciate that. Also appreciated the concept of U equals U idea. I think, moving towards that direction to expand treatment access, definitely. And we also had a comment in the chat. Love the idea of leveraging PrEP for hepatitis B care. And many folks want to be PrEP providers are not automatically considering strategies to think about integration and tackling both. Any comments or thoughts on how we might be able to get more providers on board with that, possibly?
I don't know. I was so happy to integrate PrEP into this non-clinical setting, with Program Rise, and finding that so many people, about 60 or so percent of people, clients at Program Rise were born outside the United States. It's a very international population. And folks that tend to, I think, PrEP, it's kind of, the very educated, kind of wealthy white gay men, are getting PrEP, and we need to expand PrEP to other populations. I need to confirm my speaking language, and it's so not French. I'm sorry. I don't know why I'm needing to do this right now. But it's blocking me.
I don't know how that came up. Sorry. We can hear you. Everything looks normal on our end. Yeah.
Yeah, I forget what I was saying, but there's a whole bunch of people that do PrEP work and are trying to figure out how do we get primary care docs more comfortable with PrEP. I don't necessarily think it's a purview of infectious disease or other specialty. I think it really is bread and butter primary care. And I think that unless somebody has a lot of really complicated situation, hepatitis B cares should be integrated into primary care as well. I think that's the only way to make sure that everybody gets good care for their hepatitis B.
Definitely. Yeah, thank you. And I think we have one more question from Dr. Haley Michael. Thank you so much for the excellent, clear lecture. What do you advise on hepatitis B surveillance for HCC in co-infected patients? He mentions the patients in low and middle income countries are sometimes overlooked.
Yeah. So, I was really surprised when the HIV guidelines didn't do a lot on Hep B. The Hep B guidelines really didn't talk about HIV. It kind of fell through the cracks. Now there's a little bit more, and I think the HIV guidelines are the ones that recommend start at age 40. And that's what I've been doing again for 20 years. And I've in fact picked up hepatocellular carcinoma in my patients living with HIV and Hep B co-infection. So I think that's a reasonable approach. And then again, if we don't quite understand why people, at least in the United States, what we see is people immigrating from sub-Saharan Africa, who will undergo a hepatitis B screening program, and they're 28 years old and they already have a hepatoma. They already have liver cancer. So we know that that's an increased risk, and we don't know why. It's some sort of cofactors or something. But whatever, I think HIV programs globally tend to kind of get siloed. I mean, that's my experience working in Ghana, Nigeria, Pakistan. There tends to be a little bit of siloing, and so they're not thinking about some of the advances that people have in hepatitis B care. So, in the area I was working in Ghana, one of the ID docs just started doing ultrasounds herself, learning how to, read them, and then was actually injecting hepatomas with, I think like 100% ethanol, and getting good temporary results. So there's some creative things happening out there, even when people have very limited resources. And maybe that's like a future, a future topic is, share some innovative best practices that aren't like what's showing up in New England Journal of Medicine for, highly resourced countries.
Yeah, definitely. I wonder, Dr. Haley Michael, do you have any experience with co-infection and what that might look like from the Ethiopian context that you could share?
If he's talking, he's on mute.
Oh, yeah. Let me see. I'll ask him to unmute. Oh, there he goes.
Yeah, sorry.
No
So
problem.
can you
No
hear
problem.
me now?
Welcome.
Yeah.
you.
Sorry, I think I agree with the concept that has been raised by Dr. Camilla Graham. So, like patients with HIV, especially in our country, they are left to the ID, and when it's decentralized, they are completely left down from the follow-up from the hepatologists or the ID doctors when it's such decentralized, and to the primary care workers. And with Hep B and HIV, because they have also low viral load and probably occult infection, and because hepatocellular carcinoma is also high, even with low HBV DNA, they present to us late with advanced HCC. That is the fear we have. Like we encounter them initially with HCC while they are on follow-up in other centers. So that was what I read this point, and I agree. It's important. There are other factors that could also play a role, and surveillance into the HIV guidelines for these hepatitis B patients might be helpful.
Yeah, I think
Thank you.
talking to the WHO
Yeah.
about this would be helpful.
Yeah, I agree. I think there is also, I think it's a timely topic as well, because there is a lot of topic about integration, and a lot of the integration conversations that I've heard have been around the test and treat, but I think the surveillance is something that is really important to think about, especially with the integration aspects here. So I think this is really important to think about, and also continue bringing that forward.
Well, and then the other thing is, you'll have somebody who has, a Cepheid unit for HIV viral loads, but then they're not doing the hepatitis B viral loads. And you can usually get pretty good prices on your Hep B viral load cartridges as well. And so, it's like that machine will do Hep C viral load, Hep B viral load, HIV viral load, your TB testing, but all these programs are siloed. And there's just not enough resources for everybody to buy a unit for every single, care center. So I think there's so much we can do in terms of integration.
Definitely. Yeah, thank you. I think, there's also, we have to make sure that the Hep B folks are at the table when we're talking about integration too, because I think the community can be left behind in that conversation. So yeah, definitely. Awesome. Any other questions, comments for Dr. Graham?
And feel free to share my slides. I mean, I
Perfect.
see this has been recorded, but if people just want the slides, yeah, feel free to take them.
Amazing. Thank you. We really appreciate you being here. And just given the timing, I think we are going to probably forego our case presentation today. just because I don't think we would have enough time to really get into it. But I think we had a lot of rich discussion, and want to really appreciate Dr. Graham for being here, and our advisors as well for being on the line, Dr. Torgerson as well. I hope that you will complete our continuing medical education and feedback survey. Fiona is going to put that in the chat now. If you would like to receive CME, you do have to fill out that survey, and we'll be sending your certificate via email in the coming couple of weeks. Also, that survey will help us get feedback for the next iteration of this program. So we hope that you will take time to fill that out and provide any sort of suggestions or feedback that you might have to us, so we can continue to improve upon the program as well. But I hope that all of you have a great rest of your day. Appreciate you all for being here. And please don't hesitate to reach out if you have any questions, comments, or interests in collaboration on anything. We're happy to always have conversations about those things. So thanks everybody once again. And thank you again, Dr. Graham, for your excellent presentation today.
Thanks.
Thanks, everybody.
Anything.
Thank you.